report that we published about 1 year ago. It's a clinical pathological report and challenge a little bit the clinical diagnosis of Parkinson's disease. This is a 16-year-old man that came to my office 10 years ago because of dreaming acting behavior during sleep. And in his first visit, he denied the presence of cognitive or motor complaints. And also there was no depression, hyposmia, constipation. The neurological exam was completely normal. UPDRS score part 3 was 1. And the normal cranial MRI was normal as well. So as I said, we were following this patient for 10 years and then REM sleep behavior disorder was confirmed by polysomnography. And at the age of 72, he developed hyposmia. There was in the transcranial sonography substantia nigra hyperechogenicity. At the age of 73, he had an abnormal data speck here in the right side. Also, he developed depression, and at 75 years, he had mild cognitive impairment, no dementia, but complaints of memory problems that were proved by cognitive test. At the age of 77, he died he had constipation, and when he died from lung cancer, and he was a brain donor. There was no Parkinsonism and no dementia. So he was a brain donor, and he donated the brain. And we found exactly the same neuropathological pattern of Parkinson's disease, which is Brach stage 3. That means neuronal loss and Lewy pathology in the olfactory bulb, the dorsal motor nucleus of vagus, the subcerulous nuclei, the substantia nigra pars compact duct, where there was a 30% cell loss, the amygdala, the nucleus basalis of Meiner, and the cortex was preserved. And also very interesting, there was alpha-synuclein deposits in the peripheral autonomic nervous system, like in the stellated ganglia, the sympathetic chain, the cardiac plexus, and mesenteric plexus. What I'm trying to say here is that from the neuropathological point of view, this is clear Parkinson's disease, even with a stage 4, reaching the amygdala, but the patient died and he had no Parkinsonism at all. And also this leads to the concept of premotor PD or prodromal stage of PD that we can define as a period of several years or even decades where there is a progressive neuronal loss before the clinical appearance of the motor symptoms, Parkinsonism, which allow to diagnose the disease according to current diagnostic criteria. But what is interesting to say is that non-motor symptoms may appear during this premotor or prodromal phase. This is a classical cartoon of the natural history of Parkinson's disease, where here we have the numbers of cells in the substantia nigra, and we have here the time. As you can see here, with the aging process of human, there is a cell loss in the substantia nigra, like in everywhere in the brain, but there is a point here, a crucial, critical point, where the cell loss is increased from pathologically. And then there is a decrease in the cell loss until there is a time when you, as a doctor, can diagnose Parkinsonism because of the presence of motor symptoms. And since the onset is insidious, the disease is diagnosed several years or months later on. What is interesting is that you have to reach about 60% of cell loss in the substantia nigra for Parkinsonism to appear. And what is interesting as well is that during this premotor or prodromal stage of Parkinson's disease, you can identify at least 4 conditions like hyposmia, constipation, depression, and REM sleep behavior disorder. And it's also challenging to say that for me, the disease onset starts here, where the neuropathological process starts and the hyposmia, constipation, depression, and RBD may appear. So what is also important to say is that perhaps here neuroprotection is when you have the most chances to interfere with the neurological process. Maybe when you start here in what is called early PD, the process is maybe too late or too advanced. But the crucial thing is try to identify these patients in the general population or in the medical institutions that they have hyposmia, constipation, depression, and RBD, and no clear and no Parkinsonism at all. So this prodromal stage concept fits very well with the pathological staging of PD progression speculated by Brack and colleagues, where it says that the disease, from the neuropathological point of view, starts in two places, in the lower brainstem, in the medulla, or in the bulbar olfactory, which is it carries the smell, and the disease advances from the caudal to rostral areas, from the medulla to the pons, to the midbrain, where there is the substantia nigra, and to the limbic system. And it fits also very well with the presence of this prodromal stage. If you have a disturbance in the medulla, in the nuclei of the motor vagus, you can have constipation. You have a lesion here in the dorsal raphe, you can have depression. You can have a lesion in the subcerulus here in the pons, you can have RBD. When you reach the midbrain, you have Parkinsonism, and then hallucinations, and then dementia in the cortex, and hyposmia here in the olfactory bulb. So this is from the neuropathological point of view. But what about from the clinical point of view? So these are, for example, 4 studies where the authors simply ask their patient that they have just already diagnosed with Parkinson's disease what they perceive before the diagnosis and for how long, how does it started. And you can see here hyposmia, constipation, depression of RBD started about several years or even decades before the onset of Parkinsonism, before the formal diagnosis of Parkinson's disease. And what is the frequency of these non-motor symptoms reported by untreated and de novo PD? So it's hyposmia around 40% of the patients, constipation around 40% of the patients, depression around 40%, and RBD in 30%. Not everyone, but some of them. So this is asking our patients clinically, but what about if we perform some tests or instruments or tools to our patients that we have just diagnosed with Parkinson's disease? So in this study by a German group, they found that when compared with controls, ancillary tests showed that 159 de novo PD patients had, when compared with controls, worse smell function, higher mean heart rate, REM behavior disorder, and hyperreactivity of the substantia nigra. So it's not only clinical symptoms, but also dysfunction in some instruments. So what in general or overall are the premotor manifestations of PD? The main are hyposmia, constipation, depression, and RBD, but others have been also described, like pain, erectile dysfunction, and so on. What about hyposmia and premotor PD? Hyposmia may precede Parkinsonism onset around 2 to 5 years, and there are 4 examples of how hyposmia may occur in premotor PD. First, because de novo PD patients report hyposmia precede Parkinsonism in 40% of them, which is more than in the general population. Second, because relatives of PD have hyposmia and abnormal DAT scan. 3, because patients with idiopathic hyposmia commonly have depression, constipation, RBD, and abnormal transcranial sonography or DAT SPECT. And also, as the first line of evidence is that longitudinal follow-up of aging men with idiopathic hyposmia shows an increased risk for PD. What about constipation in premotor PD? There is this classical seminal study published in Neurology in 2001, where there is the Honolulu study, which is an island, where this large amount of people, more than 6,000 people, were followed for this large period of follow-up, 24 years. This is an epidemiological-based population study, and they found that the risk of PD in men was, with less than 1 bowel movement per day, increased about 2-fold excess when compared with men with 1 day. And also it's very interesting to say that the alpha-synuclein, you can find it in the gastrointestinal tract. For example, in these recent papers, it has been shown that the presence of colonic submucosa of alpha-synuclein inclusion were found in individuals with early untreated PD, de novo PD patients, but also in individuals with PD that underwent colonic biopsy for several reasons, 2 to 5 years before Parkinsonism onset. So the alpha-synuclein was in the colon before Parkinson's disease was diagnosed or at the time when it was diagnosed. Also, we have some evidence that depression can also be considered as a risk for Parkinson's disease and constitute one of the items of the prodromal PD. We have a classic paper published by our group in 1986, saying here, even in the abstract, that in 15 patients, depression began before the symptoms of Parkinson's disease with a mean years of 5 years. And also we have another epidemiological-based population study showing that among 1,000 depressed and 67,000 non-depressed people were followed by 10 years. And depression had a 3.13 risk for the development of Parkinson's disease. So again, we have papers that were focused on patients or in the epidemiological-based studies. So what are the premotor stage of PD? So hyposmia, constipation, depression, and RBD. But as you know, these hyposmia, constipation, and depression are very common in the general population. So most of the people with hyposmia in the street, or constipation in the street, or depression in the street will never develop Parkinson's disease. It's a risk. It constitutes they belong to the premotor stage of PD, but most of them will never, ever, ever develop Parkinson's disease. But what about REM behavior disorder? This is the other side of the coin. So we define REM sleep behavior disorder as vigorous dreaming acting behaviors as punching, kicking, shouting, yelling, associated with nightmares, like being chased or being robbed or being attacked. But the hallmark is to perform a polysomnogram and showing that there is an increased EMG activity in REM sleep. So in REM sleep, while you are dreaming, you are completely paralyzed. But these people are not paralyzed, and they dream and act their behaviors. And this is due a lower brainstem damage. The magnus cellularis nuclei in the medulla and the subceruleus nuclei in the pons, in normal conditions, inhibits in REM sleep the spinal cord. So this is an example of a patient with REM sleep behavior disorder. And this patient, believe me, it's asleep and it's in REM sleep. So I am recording what is happening with the electrodes on.
Que fiera esto aquí nada más, así, y con empujones. Ay, tío, ¿tú crees que puedes andar por la calle así, hombre? Mal, hombre, relajado.
Looks like awake, but believe me, he's asleep.
Vas mirando ya mal. Vas mirando mal. Yo no te conozco de nada, no sabía si eres amigo de esta gente.
So there are two clinical forms of REM behavior disorder. The primary or idiopathic one, when patients have no motor complaints, no cognitive complaints, and the neurological examination is completely normal. So it's a parasomnia, it's a sleep disorder. It's like a sleepwalking, but in the adult. And also we have the secondary clinical form when it's mainly associated with synucleinopathy. So half of the patients diagnosed with Parkinson's disease have REM behavior disorder. Most of the patients with dementia with Lewy bodies have REM behavior disorder. And most, if not all, patients with MSA, multiple system atrophy, have REM behavior disorder. But there are at least 3 lines of evidence indicating that idiopathic RBD can be the first sign of Parkinson's disease and other synucleinopathies. The first one is that longitudinal studies carried on in sleep centers have shown that RBD patients are diagnosed eventually with PD and other synucleinopathies after several years of follow-up. I'll take some example that comes from our experience in Barcelona, where we had 174 patients with idiopathic REM behavior disorder confirmed by polysomnography, and after a mean follow-up of 4 years, 1/3 of them were diagnosed with a neurodegenerative disease, like dementia with Lewy bodies, Parkinson's disease, multisystem atrophy, or mild cognitive impairment. And 6 of them were confirmed the clinical diagnosis by neuropathological postmortem analysis. So we can perform a Kaplan and Mayer survival curve with our patients and showing that after the formal diagnosis of REM behavior disorder, idiopathic RBD by polysomnography, if you follow them, after 5 years, one of the third will be diagnosed with Parkinson's disease or another condition. After 10 years is 3/4, 76%. And after 14 years, most of them. So that means that most of them, sooner or later, will be diagnosed with Parkinson's disease or other neurodegeneration disease. But the process, as you can see here, is slow, 14 years to reach 91. But still, there are some people with idiopathic RBD that look like they are resistant, that they are good in terms of they have no Parkinson's or no dementia, like this one that I have been following for several years, that he's 93 years old and still idiopathic, still kicking, alive and kicking, and doing well, rocking. So there is a second evidence that RBD can be the first sign of a synucleinopathy. It says RBD patients show features that are typical of PD and other synucleinopathies, like DLB or MSA. So if you have your patients with idiopathic RBD that they don't look apparently clinically that they have Parkinson's disease because they have no neurological motor dysfunction, but if you perform some clinical interview or some ancillary test, you will find that about 40% of them have decreased striatal dopamine transporters. 40% of them have abnormalities in the transcranial sonography. 40% have abnormal MIBG cardiac scintigraphy. Also, cognitive deficits in tests in people who complain that they are cognitively normal, hyposmia, constipation, and depression. So they are typical things of Parkinson's disease. For example, in this study that we carry on with 44 idiopathic RBD patients and 40 matched controls, we found that hyposmia and constipation were more frequent in patients than in controls. So it's always the same story. So the thing is that, so you have your sample with idiopathic RBD, and you see that most of them will develop Parkinson's disease or another, but who are the ones that they have more risk or a very early risk to be diagnosed with Parkinson's disease? So we have some studies coming from our group and from the Montreal group showing that those patients with abnormal data scan, abnormal transcranial sonography, hyposmia, or color vision are the ones who have a short-term between 2.5 and 5 years conversion to Parkinson's disease and dementia will be everybody. So it's RBD plus one of them, data scan, transcranial sonography, hyposmia, or color vision means high short-term risk of developing PD or DLB. And we have this cartoon that Lady and the Tramp, 1953, so it's about 30 years before REM behavior disorder was formally described. And you can see one of the first descriptions of REM behavior disorder. Can you use the sound? So this is an old dog sleeping and having dreaming acting behaviors.
He's dreaming.
Aye, dreaming of those bonny bygone days when he and his grandfather were tracking criminals through the swamps.
They were?
But that was before...
Before what?
'Tis time you knew the truth, lassie. It shouldn't have happened to a dog. But, well, Trusty has lost his sense of smell.
No.
Aye. But we must never let on that we know, lassie.
So Trusty is an old dog
Poor heart.
with REM behavior disorder and hyposmia, so short-term risk to develop Parkinson's disease. We'll take care of him. So what about the progression of these abnormalities in patients with idiopathic RBD? We have to monitor the disease if we can. Well, one thing that you can do is try to do it with a cheapest way, for example, with a smell test. But the smell doesn't decrease over time in patients with idiopathic REM behavior disorder. Here is the UPSIT score in 40 patients with idiopathic RBD. So at baseline, it's only 17, but 1.5 years, 3 years, and 4 years later, it's still the same. So it's abnormal when compared with controls, but it doesn't worsen over time. It's stable. And the same goes with the echogenicity of the substantia nigra is stable with time in idiopathic RBD. So you can you can measure here the substantia nigra echogenicity, but after 5 years, it's always the same size, so no progression. But there are two other instruments that can show you progression of the disease and monitor the disease. This one, for example, is the striatal data uptake in decreases with time in idiopathic RBD. As you can see here, the sign, the dopamine transporting imaging uptake decrease over time clearly until the patient is diagnosed with Parkinson's disease. But here is abnormal at baseline, more abnormal, and more abnormal when you diagnose with Parkinson's disease. And also the same goes with cognitive function. Your patient with idiopathic RBD at baseline can be cognitive normal, but if you perform cognitive tests over the time, you will see that the cognitive function declines. So the third evidence is that living idiopathic RBD patients show subnucleum pathology. I'm talking about living patients, not post-mortem studies. So this is a study that was published in Neurology by our group with Innsbruck team. It's a collaboration, and it was published 3 or 4 weeks ago. And we performed simply colonoscopy to our patients with idiopathic RBD. And we found that phosphorylated alpha-synuclein was found in 4 of the 17 patients with idiopathic RBD and 0 of the 14 healthy controls. So I think that this is challenging the diagnosis of Parkinson's disease. So imagine that you have a patient that comes to your offices with a clear story of REM sleep behavior disorder that you are even able to confirm by polysomnography, and then they perform, or some perform the colonoscopy, and you have alpha-synuclein in your hands. So for me, I mean, if it's not Parkinson's disease, what is this? So the conclusion of this talk is that hyposmia, constipation, and depression and RBD are components of premotor PD. RBD is the most specific component of premotor PD, and idiopathic RBD is a good target population to test neuroprotective interventions. We are early in the process. And these are first thoughts for future neuroprotective trial in idiopathic RBD. First, you have your patients with idiopathic RBD well confirmed by polysomnography. The primary outcome, it's obvious, reducing the incidence of MCI, dementia, DLB, PD, and MSI over time. The secondary outcome, you have to monitor the disease process with some instruments able to show you this. For example, reducing the progression of striatal data uptake, performing data scans, and neuropsychological deficits, performing neuropsychological tests. So the assessments will be serial clinical interview, neurological exam, data spec, and neuropsychological testing. The trial duration, it has to be quite long, or a little bit long, between 3 and 5 years, to have a 30% conversion rate as a speculation. And the intervention can be, well, I don't know. But one of the things is targeting alpha-synuclein, sit, and spread over the brain. Thank you very much for your attention.